but not all of those people were neo-Nazis. There was a group on this side, you can call them the left, or you've just called them the left, that came violently attacking the other group. So you can say what you want, but that's the way it is. I think there's blame on both sides, and I have no doubt about it, and you don't have any doubt about it either.
Well, in a moment, we're going to be speaking to our US correspondent Cordelia Lynch, who's live in New York. But first, James Matthews is live in Charlottesville for us this evening. Hello to you, James, and that is where the funeral service took place earlier on today for the young lady that lost her life at the weekend. What was the atmosphere like there?
Well, it was sombre, Kay, principally, but it was one also of celebration, and the talk at the service inside a cinema in downtown Charlottesville, you know, remembered her for what she was, an activist who was out on the streets on Saturday because she was standing up against the far-right extremists who had descended on Charlottesville from around the United States. I'm standing in the very centre of that protest, and it is to do with this monument to my left, and that man you see there on horseback. He is General Robert Edward Lee, represents the Confederate United States, which was fighting for a number of things, principally the subjugation of non-whites. And you see there, this is a place that goes by the name of Emancipation Park, today renamed with a piece of cardboard Heather Heyer Park. Somebody was up this morning putting that sign in place. This is where the far-right activists had gathered because they wanted to protest at plans to bring down that statue because of what it represents, the values and the beliefs of the old days that blighted Charlottesville. So that's the history. In terms of the present day, like I say, it was celebration at this memorial service for Heather Heyer. A number of speakers, including her mother, Susan Bro. This is what she had to say about her daughter.
They tried to kill my child to shut her up. Well, guess what? You just magnified her. So here's what I want to happen.
Testing,
You ask me, what can I do? So many caring people. Pages of pages of pages of stuff I'm going through. I'm reading pages of pages, how she's touching the world. I want this to spread. I don't want this to die. This is just the beginning of Heather's legacy. This is not the end of Heather's legacy. You need to find in your heart that small spark of accountability. What is there that I can do to make the world a better place? What injustice do I see and want to turn away? I don't really want to get involved in that. I don't want to speak up. They'll be annoyed with me. My boss might think less of me. I don't care. You poke that finger at yourself like Heather would have done, and you make it happen.
There we are, Susan Bro, the mother of Heather Heyer, looking to the future, looking at the values and principles of her daughter. Out on the streets on Saturday with Heather here was Tanisha Hudson, who joins me. Tanisha, you're a local activist. You came out to this park, this spot, on Saturday to protest against this far-right demonstration. Tell me why. What are your feelings about the people who came to this town and that statue that stands to your left?
Well, I feel like this statue is a mock to the African American community. It's a mock to my ancestors. It is a statue that represents all the lives lost in slavery. So you mock us with this. They didn't win. There's no victory in Robert E. Lee. He was on the wrong side of the fight. He deserves no street. He deserves no statues. He deserves no schools. He lost the battle.
On Saturday, Donald Trump said there were two sides to that. You were out on the streets, and you were on one side. What do you think of his statement yesterday that there were two sides to blame?
Well, Donald Trump said that people were out there with no permits to protest, which was false news, as he say, because everyone had to file a permit to protest. So we had permits like everyone else to be out there. And it's okay, they were on one side, we were on the other. But where was the protection for the people that pay taxes in this city?
Generally, his statement yesterday in Trump Tower, what do you think that says about your president?
I think our president is taken up for his brotherhood, for his friends, for his homeboys, for his partners. I think he's making an excuse for them. He's the same guy when running for president that said, do they know what would have happened to them if they would have came in here years ago? They would have left out on a stretcher. You okayed this activity. And along with Charlottesville, the President of the United States needs to take full responsibility for allowing these people to come here and destroy this city and lay this bloodshed on Charlottesville.
Tanisha Hudson, thank you very much indeed for your time here in Emancipation Park, renamed for the day Heather Heyer Park.
Thank you. Just receiving a statement from the CEO of Campbell Soup. Racism and murder are unequivocally reprehensible and are not morally equivalent to anything else that happened in Charlottesville. I believe the President should have been and still needs to be unambiguous about that point. And with that, she is the 8th CEO to resign from Manufacturing Council. That news just reaching us. Let's bring in Cordelia Lynch. So although he suggests he still has the support of many rank and file members of the United States who voted for him, it looks as though the CEOs are starting to gang up against him.
Yes, business leaders deeply concerned by the tenor and tone of his words yesterday, and Donald Trump very frustrated at the continued backlash against his remarks regarding Charlottesville. The White House sent round some talking points in a memo today to Republican loyalists to Donald Trump, saying that he was correct, that both sides did act inappropriately and should shoulder some of the responsibility. It makes the point as well that Donald Trump did call for an end to violence and unequivocally condemned racial hatred and bigotry as well. Nevertheless, many within his own party today not directly criticising him, but issuing their own unequivocal statements, including former presidents George H.W. and George W. Bush. In a statement, they said, America must always reject racial bigotry, anti-Semitism, and hatred in all forms. Now, Donald Trump yesterday was seen as undoing what he did on Monday, which was try and calm the waters and clarify his position. I think we've seen in his language yesterday and his tone as well that he feels deeply misunderstood, Kay.
Not by his loyal gatekeeper, Hope Hicks, who has been promoted.
Yes, Hope Hicks, 28 years old. She has been a loyal confidant by his side, a big feature on the campaign trail as well when he was running for president, and she is now taking up the role of communications director, but it is a temporary position. She's taking over from Anthony Scaramucci, who only lasted 10 days in the job. Donald Trump has been very complimentary about Hope Hicks in the past. One of the most important people in his political orbit. She is in control of trying to communicate his message, but she'll be keenly aware, of course, that Donald Trump is, in effect, his own communications director. And talking of the president, here at Trump Tower, there's some activity. We're expecting him potentially to be here shortly. He's going to be heading on to New Jersey to his girlfriend. And, of course, lots of questions that the waiting press have for him today.
Okay, for now, thank you. Back home, politics here. Sarah Champion has resigned as Shadow Women and Equality Secretary and apologised for what she called her extremely poor choice of words in a newspaper article about child abuse. Labour MP said she was concerned that continuing in her shadow cabinet role would distract from the crucial issues around child protection. For more, let's speak to our political correspondent, Tamara Cohen, who is standing by in Westminster for us this evening. Hello to you, Tamara. What's the background to this?
Well, Kay, this is a growing criticism of an article which Sarah Champion wrote in the Sun newspaper on Friday. This was following the convictions of 17 men of various Asian backgrounds for the abuse of young women in Newcastle. Now, Sarah Champion, who is the MP for Rotherham and also in the Shadow Cabinet as the Shadow Minister for Women and Equalities, has campaigned for many years on the issue of child sexual exploitation after a huge scandal about it in her own constituency a few years ago. Now, the headline of that article was very provocative, and this is what it was. It was British Pakistani men are raping and exploiting white girls, and it's time we faced up to it. And she talks about the problems of police and authorities not responding to some of these girls when they bring complaints, she says, because they fear being accused of racism. Now, there was a big backlash on social media saying against Sarah Champion, saying that she was demonising this community. This also came from some of her Labour colleagues. One of them, Naz Shah, Labour MP, said that she used blanket and racialised language. There were even calls for Sarah Champion to resign. Today she has done so, and this is what she said in a statement this afternoon. She said, "I apologise for the offence caused by the extremely poor choice of words in the Sun article on Friday. I am concerned that my continued position in the Shadow Cabinet would distract from the crucial issues around child protection, which I have campaigned on my entire political career." We also have a short statement from the Labour leader, Jeremy Corbyn, who said he has accepted Sarah Champion's resignation, thanks her for her work in the Shadow Cabinet, and says, "I look forward to working together in future." So rather sounds like she jumped before she was pushed, if you like. I think Sarah Champion will be upset about this. She clearly feels that she misjudged it. She's since complained that she wasn't happy about the headline in The Sun, although The Sun hit back saying that she was perfectly happy when she saw it on Friday. But clearly she feels that in this crucial area of child protection work, it would be better if she took a step back, having made what she clearly sees as an error of judgment, and resigns from her Shadow Cabinet post.
Okay, for now, thank you. So you remember, of course, that several CEOs have been stepping back from both the Strategy and Policy Forum, also the Manufacturing Council in the United States as a direct result of Donald Trump's comments, many of those feeling that he has been unacceptable in his behaviour as far as Charlottesville is concerned, and lack of condemnation thereof. The latest we heard from that was the CEO and chairperson, president, I should say, of Campbell's Soup, and she had said that she would be stepping back from the Manufacturing Council as a direct result of what the president had or had not said. Well, we've heard from Donald Trump within the last few moments. He says, rather than putting pressure on the business people of the Manufacturing Council and the Strategy and Policy Forum, I am ending both. Thank you. Government's latest position paper on leaving the EU rules out the need for a hard border between Northern Ireland and the Republic. The post-Brexit plans effectively recommend no change to the current arrangements. Speaking earlier, the Irish Foreign Minister said although he welcomes the plans, more clarity is needed.
The British government has chosen to essentially take an approach of setting down 9 principles for negotiation. The vast majority of those principles,
Testing 1, 2, 3. Testing 1, 2, 3. Can you hear me? Over.
We're good.
All right. So I got my mic on, I think. It should be working. So I'm trying to get my 15 minutes of fame in. Probably could turn the room volume down a little bit if we can.
That's how it's catching, actually going across. That's how loud it has to be.
Oh.
It's a line volume.
Okay. All right. Airways we're going to talk about today. Stuff you want to talk about before we get into this? It's broadcast to the entire world. No, I think there's one person watching. So, recent runs, issues, obnoxious flags you've gotten on a chart you want to talk about. Any issues or questions or protocol things or anything? Open forum. Nothing? All right. Everything's perfect. I'll take it. We're talking about airways because they matter, and it's a big deal. Any recent airway runs, anybody? Yeah? Tell me about it.
Overdose of cardiac arrest.
From heroin.
Yeah, heroin overdose, cardiac arrest.
Found what rhythm?
Asystole.
Who did the tube?
Not me.
Not you. Who did the tube?
It's not. It was a fourth part.
Oh, okay. Gotcha. Easy tube?
Yeah, it was pretty easy. There was a pretty good amount of vomit, but they used King Vision and got it first try.
So a video device with vomit in the airway, and it went okay. Suction before they put it in?
Yes.
Yeah, that's the secret.
Right.
Once it's contaminated, you're kind of screwed, but if you can suction before you put it in, a lot of times you'll be okay. But having had, at least recently, 2 really bloody contaminated airways that I was able to, that VL would have failed on, I was able to DL. Just keep up those those old-fashioned skills too. Who's used the King Vision? What do you think?
I like it.
It's not that new. I thought it was new just because I've been here for now going on 4 years, but y'all have had it for about 1.5 years, 2 years, right? And you like it?
This is Brown County.
Brown County. Okay. Anybody used it here so far? Yeah.
I haven't used it, but it has been used. It's been used.
Yeah.
It's been used a long time.
Yeah, I know Marcus used it a few weeks ago.
Yeah, Tony Bell used it recently, but it's not here.
I like it personally. You just have to remember that you can't put an 8.0 tube in it without much difficulty. 7.5, even the 7.5 needs a lot of lube. I don't did something just, yeah. Yeah, I like the King Vision. The issue is always going to be currency, right? Because the King Vision will fail you when you might need a device like that the most, which is a bloody, contaminated, disastrous airway. And those traumas, those people with facial trauma, they're going to be hard to bag up anyways. They're going to have terrible reserve. So it ultimately comes down to finding who is the most experienced with direct laryngoscopy on the entire team. And they might be the ones to do that intubation. Or that's the one where you need to put in a King sooner as opposed to later. So today we're just going to talk about some of the basics that include anatomy, the indications for intubation, or any sort of airway management, what I call the predictors of doom. I try to take a more simplistic approach. Some of you may have heard out of the Difficult Airway Manual written by Ron Walls and the Difficult Airway course and all that. They got like lemon, rods, moans, whatever. Who's heard of this? Yeah, I don't find any of it particularly useful because it's not something that I have time to think about in the middle of a patient that's kind of crashing and circling the drain. Some pitfalls, some pros with respect to airway management. We'll try to do some hands-on stuff actually toward the end instead of throughout, and then kind of a wrap up. So for those of you that were here, this is a talk that we gave in 2015 that I think probably we almost should do every year, but we're doing about every 2 years. Because this is bread and butter, right? This is why those of you that really enjoy the EMS side of your jobs may enjoy it, is taking care of sick patients, and often sick patients involve needing to have their airways protected. And the kind of unfortunate reality is none of us probably do this enough. I mean, as somebody that has like 100 plus intubations, there are some times where I still have gone months without intubating and I may feel a little rusty. So it happens to the best of us, and the only way to stay on top of that is to, number one, get really good training up front so that it becomes muscle memory. And for those of you for whom it's not yet totally muscle memory, meaning the difficult airway is not yet something that you feel like you can troubleshoot, well, pay attention and maybe we can try to get you more experience. Have they ever talked to you guys about OR opportunities? Has that been circulated as something for paramedics? It's, but I can continue to try to talk to the chief about it and see if that's something that would be worthwhile. I think the issue would probably be orchestrating pay for it too. Or you feel like you need more hands-on time intubating than you currently have. Really bad head traumas or altered patients that are already trying to die. And I hear you, and that's a frustrating thing. And there's no easy solution for that, unfortunately. But it makes paying attention here, doing some so we realize that a lot of people have varying levels of experience here, and I certainly appreciate that because I realize that you can go into it and have a crew full of inexperienced and experienced intubators, and it's kind of a balance between helping each other out when you can and putting the most experienced person first versus giving the new person an opportunity to gain some airway management skills. And that is a difficult balance that kind of depends on the patient, right? There are the codes that we think are viable where you need to keep hands on the chest and the airway's clean, and the airway's dirty, and it looks like it's going to be a tough situation that needs the best person on deck, the most experienced intubator. And then there are codes where they've been unwitnessed, asystolic, but we're working it anyway because the body was warm, they had no lividity, whatever it is. Maybe that's a better opportunity to let somebody new come in. But it's kind of something you have to figure out ahead of time among the crew, and just be mindful of that balance whenever you have the opportunity to intubate. A lot of the stuff that I am going to talk about here, just like I mentioned the last time, is these are all sort of helpful hints. These are just very little, there'll be some evidence here, but there's very little core evidence. A lot of this is just stuff that I've gleaned over years of trying to get really good at this and be able to troubleshoot difficult airways. And just remember that this is something that can be life-saving in the right circumstance and can be also what we call a clean kill in medicine. So you intubate the right person at the right time and you'll just straight up kill them. And they would otherwise be alive if you hadn't intubated them or if you hadn't tubed the esophagus and missed it. So it's definitely a high stakes thing. Basic anatomy, y'all know this stuff, I'm sure. I think the key point here is the epiglottis, and what is this space right here? The vallecula, yeah. This is honest to God, this is really all there is about intubation. Everybody gets excited about the vocal cords, but I'd say if you just gave me an epiglottis and there was some little something here, but nothing really specific, you could still get the tube because the epiglottis pretty much guides everything you're going to be doing. We'll talk about that. The vocal cords themselves is what you're looking at. I'm going to refer to this as posterior notch. And this is something that you'll see in a grade 2 view when you have a partial view of the cords but not a full view. And this is going to be your roadmap to the cords because what's right underneath this? Yeah, where you don't want to go. This guy, it's not actually labeled here, but there is a ligament back here at the very back called the hyoepiglottic ligament. Why is that ligament important? Actually with the MAC. Yeah, with the MAC. But exactly right. That's the ligament that you want to trigger. And do you trigger that by lifting up as hard as you possibly can? No, it's a loaded question, right? You trigger that by making sure you're locked in the vallecula, and we'll talk about that because I think that's where a lot of intubations go wrong. Boring anatomy review we're going to skip. I'm not feeling like anatomy today. So, but does anybody have any more questions about that basic structure? I mean, we know the vallecula, epiglottis are all important, blah, blah, blah. Don't put in the goose. So why do we intubate? We intubate to protect somebody's airway, so in somebody that's unconscious. Classically, the teaching is like GCS less than 8 intubate. That's not really true. What is it a question of? When we say we're intubating to protect somebody's airway, think about like in the ER, like when somebody rolls in and we're like, all right, we're going to give them drugs, we're going to give them ketamine and rocuronium and take them down to protect. We're intubating for airway protection. Why are we doing that? Like, what kind of patients need their airway protected? Rapidly deteriorating. Right, so if their respiratory drive's at risk. And then just for airway protection, just for that, patients that have a gag reflex or don't have a gag reflex, does that matter? We've all heard something about the gag reflex in airway. Doesn't make any difference. They've studied it. Doesn't make the slightest bit of difference whether you have a gag reflex or not. Okay, I mean, there are people that walking around don't have a gag reflex and they're awake and talking. It is more a question of are they able to handle secretions? So is there pooling of secretions in the airway? So if they're not able to swallow and if they're not able to clear their airway of secretions and there's pooling of secretions or gurgling, those are the people that we're going to end up intubating in the ED. Or in the cases of somebody that's GCS of 4 or GCS of 3 that's pretty out of it, those are people that you all may be able to intubate without any drugs. Somebody that's going into respiratory failure and can no longer oxygenate or can no longer ventilate their CO2. Cardiac arrest, and those are pretty much the main 3 that we're going to see here. Obviously, these 2 are going to be pretty far gone to tolerate intubation without drugs, unless y'all are feeling up on your nasotracheal intubation skills. Who's intubated nasally? It's not in the protocol anymore. Yeah, and I think that's probably for the best because a lot of times you're going to run into more harm than or doing more harm than good there. I've done it a few times under fiber optic guidance. That's a lot easier than trying to do it blind. Blind nasal airways are not very common anymore because they have a risk unto themselves. But so these 3 are the main indications. So first, let's think about who are the people that are going to be difficult to bag. So these are the people that are going to lose their oxygen reserve pretty quickly. And a lot of times we think about people with facial hair as being challenging, and I think that's totally true. You can troubleshoot that, though, with 2 ways. Usually one is to lube up the beard. So you can apply just regular old KY jelly lube around the beard that will actually help maintain a seal. The other thing is, I don't know how big the tegaderms or if you guys use VenaGuards for your IVs, but you can get a big tegaderm and actually cover their mouth with it. It seems kind of weird for a second, but then you poke a hole in it, and that tegaderm will basically stick down their beard and create a good seal for you. I've done that in a pinch. People with sleep apnea, because when they go unconscious, their oropharynx, their hypopharynx is all going to kind of collapse backwards and obstruct their airway, so they'll be hard to ventilate. And then the people that are rotund or obese, we're going to usually favor a nasal or oral airway in these folks. And if we get to the point where we need to ventilate them, they're probably not going to do fine with just a draw thrust. They might need a little bit more than that. And then people who have dentures, which you remove and are then thus edentulous, they lose the architecture of their face. So what I found helpful is to seat the base of the mask in the mouth. Remember this with an acronym HARD, which to me is a little bit easier than lemon, rods, moans, whatever. Difficult intubation. So who's going to be difficult to intubate? These are all general rule of thumb. And honestly, at this point, I prepare for the worst because I've had people that have no predictors of difficult intubation be very, 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 very difficult. And that's why I prepare in all my intubations. I kind of set up all the stuff I might need. I got my backup airway, my king. I'm ready to troubleshoot with different incisor distance. So if you have an inner incisor distance between your teeth that is less than 3 fingers at maximal mouth opening, so you can't fit 3 fingers or more between somebody's teeth when their mouth is open, that's going to make it harder, just in terms of your view and being able to negotiate their mouth opening. If they have a Mallampati score greater than 3, meaning if you cannot see the uvula at the back of their throat when they open their mouth and stick out their tongue. If they have a thyromental distance, so thyroid up to chin, of less than 3 fingers, they're going to be a pretty short airway to negotiate. It's going to be pretty tight. And if they cannot extend their neck any more than 30 degrees, or the back of the head, it's going to help with your view. And we'll talk about that under troubleshooting. But if they can't do that because of whatever, I think I've had a guy with previous cervical spine surgery that wasn't able to do that. Or if they're immobilized, it makes it a lot harder. That's just a review of the Mallampati. So the Mallampati score 3 or 4. So let's just talk about kind of the, I always call it the kumbaya stuff for a little bit, because I love my kumbaya stuff. So having a written checklist is really most important. We do high stakes stuff just like airline pilots do every day, where, admittedly they could kill 130 people at a time. We could just kill 1, but the stakes are high nonetheless. So we 12 things that I need before I do every intubation, and I can run through it pretty much in my head because it's an acronym. Introducer device, do I have my rescue device, do I have my waveform capnography, do I have my ambu bag, my Ankower suction, do I have my apneic oxygenation, my stylap, my syringe, my ET tube, my tube tie, and do I have a scalpel to help me? What you don't want to end up in is a situation I've been in the back of an ambulance myself. I was not the primary intubator, but I was helping with the intubation, where we get the tube and all of a sudden we realize we hadn't grabbed the BVM. We had no, I'm just you grabbed the BVM and we fixed it, and it was not a big deal. But be mindful, if you're going to do any airway procedure, even in a cardiac arrest, take the 10 seconds to just kind of cross-check and make sure you have all your stuff. Stuff that I have on my checklist, like I just mentioned.
Well, hello, nice to meet you. John, is it? Nice to meet you. How are you?
Hey, I'm Danielle.
Oh yeah, good stuff. Right, so we're going to anaesthetize this gentleman who's got to go to theatre. He's been in ITU with us.
Let me see if I can turn up the sound here.
Just getting pre-optimized. I've got all the drugs here for our induction, which we're going to give in just a moment. So we're going to do a rapid sequence induction. Okay, so I need cricoid. Can you do cricoid?
Yeah.
Closed captioning is not very good.
Fine. Great. Okay, so you're going to hand me stuff.
Yeah.
Okay?
Yeah.
Right, so he's been on that for ages now, so let's call that pre-oxygenation, shall we?
Mm-hmm.
I'll just stick this on here. Okay, I'm going to give the drugs. You all ready?
Mm-hmm.
Okay, now let's just watch. Right, it's not breathing. Got some fasciculations. What are the stats?
Sats are about 89, 90.
Should be 100.
Oh, brilliant.
Okay, fine. Well, we'll get on with it anyway. He says, right, can I have the scope, please?
Yeah.
Right, let's have a little look.
Manage there, mate.
Yeah, I'll manage. Okay. Could you get me a bigger blade? Can you get me the other blade? Yeah. Bigger blade. Come on, come on, come on. And could I have a bougie, please? Oh, it's not out already. Come on, come on.
Alright. Ah, bollocks.
It's okay, we can use it. Just give me the bougie. Give me the bougie. My God.
So that's 84 now.
Oh, damn it. I have to vent here. This isn't working. This isn't working.
Do you need any help?
No, can you just squeeze the bag for me? Squeeze the bag, squeeze the bag. Squeeze the bag, come on. We're not moving the chest at all here.
The heart rate's gone to 30.
Okay, well, let's just quickly intubate him. Come on. Could you get me the tube? Get me the tube.
Yeah.
Tube,
Yeah.
tube, tube.
Yeah.
Come on.
All right.
Thank you. God, thank God for that. Oh no, that's must be the esophagus. Could you put the cricon on again, please? Oh my God. Go for help. Go for help. Go for help. Get anybody.
Yep. Anybody? Help!
Oh my God. There's no.
CJ.
Okay.
Oh, that's trippy. I could watch right now. All right. So what kind of stuff did you notice? The sound wasn't too great, and the British accent didn't help. But what kind of stuff did you notice there that wasn't great?
No pre-oxygenation.
No pre-oxygenation. Great. Supplies were all haphazard. They weren't ready.
Didn't realize it was time to put a rescue arrow in.
Yeah. Didn't think to put a rescue arrow in. It was basically try to intubate and then bag, and then you can't bag, and didn't try anything else. The backup plan for not being able to ventilate was to try intubating again. His technique was interesting, yeah, to say the least. So he was levering against the teeth. He was too close, hyperextending the head. His position was weird. He didn't use apneic oxygenation, which at cardiac arrest, I get it, probably not that beneficial. But anytime you're doing an airway on somebody where they're just like obtunded, their GCS is really low, you should give them the benefit of apneic oxygenation. What does that entail? Cannula at what? 6, 15? I put them on 15. I don't know if there's any difference. It's not going to harm them. There's some theoretical thought that it's actually giving them PEEP. So imagine like a mini CPAP on their nose while they're getting intubated. That helps their oxygen. I think in all my intubations that we've used apneic oxygenation on, I can think of like one patient that desatted, and they were not a very healthy patient going into it, so that wasn't a surprise. He never confirmed with end tidal. For some reason, I think he noticed the chest wasn't rising. That's why he said it was esophageal. They were just talking about heart rate. They didn't even notice the SATs during the intubation. And I think they mentioned that the patient got bradycardic, which is a good surrogate for pretty bad SATs if they're getting brady, but probably a little too late. When you're intubating, you have a patient that you've got pulse oximetry on. When are you thinking about stopping and bagging them up and trying again? What kind of SATs are we talking about? Are you going to wait till it gets to 80? When are you waiting? Yeah, conservatively 95. I'm usually a 93, 92 kind of person because that's the swing of the oxygen hemoglobin dissociation curve, where essentially it takes a fair amount to get down to 92, but after that it does not take much to go from 92 to 70 or from 70 to 50. And once a pulse ox gets below 50, it's just anybody's guess. I've seen it at 0 before with good pleth. That was pretty scary. Pitfall number 1 is forgetting the goal. What do I mean by that? The goal is oxygenation. The goal is not to intubate a patient, right? We intubate them for airway protection. That's a nice bonus. But at the end of the day, sustain that oxygen saturation by whatever means necessary, which is kind of counterintuitive because when I started in EMS, I was always told, treat the patient, not the mom in this case. It's this and stuff like hypotension and TBI that we were just to leave it. I think you can have false low pulse oxes where, meanwhile, the patient's like satting in the 80s. But nonetheless, the goal is to keep their trying and trying and trying and not back ventilating them or and not having that king in if you're taking people for what they're worth is a pitfall, just like in that intubation scenario. So remember, whenever we are washing out all that nitrogen out of their airways, Just because somebody's well oxygenated going into intubation doesn't mean we're done. At least 3 minutes or 8 full ventilatory cycles. So, and they can be considered adequately denitrogenated. Denitrogenation for most people to give them adequate reserve. So the big caveat, especially in RSI scenarios, is, and I say, well, they've got a TBI and they're all going to hurt their blood pressure at all. Well, it will. To positive pressure, where initially they're breathing on their own, their diaphragm's contracting, air's coming in, it's a negative process. BVM, we're forcing the air in. So what do you think that does to the venous return to the heart? Yeah. You could think of it as giving them nitro, because you're decreasing preload to the heart. It's just like taking somebody that's 60 on 40 and giving them a whiff of nitro. Is that good medicine? Or the same thing as putting them in a cardiac tamponade. So just remember that when you're intubating somebody, it's a hemodynamically dangerous procedure. Even if you don't use drugs, because we don't carry RSI drugs, you could still kill somebody by intubating them if they're truly in shock. So just be mindful of that. How else can things go awry if you don't check your equipment prior to your call, if you're not assembling everything the way it should be, not positioning the patient properly, which is super underrated, right? We'll talk about positioning, not positioning yourself properly. Poor technique. So trying to do it all in one fell swoop. We'll talk about that. What does that mean? Trying to accomplish the goal of just getting the tube in the trachea in one fell swoop is something I actually do not advise. Because no matter how many intubations you do, the way to navigate tricky intubations is to set markers for yourself, is to set goalposts for yourself, and that starts with the epiglottis. Not suctioning, not getting the tongue out of the way. We had a brand new R2 the other day that was doing a good job at the tube, but then I noticed he was struggling to really visualize epiglottis and really visualize chords. And I look over, and the blade's all the way over to the left side of the mouth, but the tongue hadn't swept with it. So the blade was already shifted to the left side of the mouth, but he hadn't taken the tongue with him, so he didn't have good tongue control. So of course he had poor visualization. As soon as I pointed out to him, he took blade out, reseated it, swept the tongue to the left, and boom, tube was in. Levering against the teeth is bad. The anesthesiologists care a lot about that. You know, we're in emergent circumstances, so we kind of get a little bit of a freebie there, but at the same time, you know, putting a tooth in your patient's lung when they were otherwise okay before that is poor form. And then not troubleshooting difficult views. So I want to talk about, as I've done, those of you that have heard this talk before, very tangible, simple action steps for certain situations. This isn't like, oh, well, lemon rods and moans, and if you just, you know, if you've got enough experience in this, then you're going to be okay. This is, if this, then here's what you should do. And I promise you that at least one of these things will be helpful to you if you encounter these situations. And we'll talk about this. One of the most egregious sins you can make is not confirming. Do we have waveform capnography, or do we have color here? We have waveform. How recently is that? Long time. Okay. There are ICUs. There are ERs. There are places in the country that still use these godforsaken color devices that most of the time are accurate, but a lot of times I don't know what to do with. They'll like change, then they might change back, and then you got to give them 5 breaths before they, whatever. The gold standard is waveform capnography. Every single intubation, without fail, 100% of the time, no excuses. You know, you want to confirm your tube placement for sure, but are these substitutes for this? No. Because people have been wrong many a time about lung sounds, epigastric sounds, or about tube condensation. So don't rely solely on those things. And then just remember that all this stuff like the tube fogging, the chest rise, even pulse ox getting better after you intubate them, that's all pretty much bogus. A lot of times SATs get worse after we intubate somebody. Matt, I think he's trying to give you that. Sometimes pulse ox gets worse after we intubate somebody because they're delayed, right? The pulse ox has how long of a delay?
Like 3 to 4 seconds,
Somewhere
right?
between there. I'd say about 30 seconds, 30 to 60 seconds. Yeah. Just remember, 83% of esophageal tubes in the wrong place will cause condensation. So I never pay attention to that. Some people are like, oh, you got fogging in the tube, you're good. Don't worry about it. All right, now we're going to talk about some pearls. All the green stuff is good. Green stuff is stuff we want you to do. Apneic oxygenation. We've beaten this in a few times, I think. But just remember, the nose is a great route for oxygen getting in. They don't rebreathe their CO2 like a mask. If you put a mask on a patient, insofar as you're giving them oxygen in, they're also exhaling CO2 that they might rebreathe a little bit, even on a non-rebreather. And the nice thing is you can keep this in their nose while you're intubating. So you can do it while you're intubating. 15 to 25 liters per minute, and it prolongs your safe apnea time, meaning the time that they go before they get to that 93% or that precipice on the oxygen hemoglobin dissociation curve where they're going to start to drop faster. This is invented by a guy named Rich Levitan, a super smart emergency doctor. And it's been fairly well validated in a lot of studies. They actually just came out with one in Annals of Emergency Medicine a few months ago that affirmed this, saying apneic oxygenation really does work and really does delay the time to hypoxia. Ultimately, this is his discussion of a case presentation of a patient who came in hypoxic and basically had the sort of the three problems of oxygenation, right? Positioning sucked, there was no extra oxygen on, and he had snoring respirations with SATs in the 70s. So how would you fix each one of these without even looking down in the list? How would you fix flat positioning? Sit them up. Why is sitting up better? Fluids, good. Why else?
Position of
The neck, airway optimization. And also our diaphragm works best sitting up with gravity. Like, why do people get sleep apnea when they're lying down? Part of our diaphragm's work also involves kind of contracting with gravity. So when you have somebody sitting up, that also decreases the weight of the intra-abdominal organs on their chest cavity. So we'll all the time, we'll take somebody that's hypoxic in the ED, maybe they're intubated on the vent, having a little bit of difficulty, especially if they're obese, and we'll take their stretcher and go from like this to head of bed up and then tilting the stretcher in like a reverse Trendelenburg, and we'll see their SATs improve pretty readily. So sitting patients up, how would you manage this? Easy. O2, could be nasal, could be mask, and this? OPA or NPI. My go-to is an NPA unless they're like in cardiac arrest, because otherwise you get surprises with an OPA. Yeah, so all it is a matter of sitting the patient up, giving them extra oxygen, and putting in an airway of some sort, or jaw thrusting them. All right, how do we pre-oxygenate the patient? We've talked about this. However they need to be pre-oxygenated. So if you've got somebody in respiratory failure that you think is going to basically die in front of you and go from having a hard time breathing, being awake, to being near a GCS of 3 where you're going to have to intubate them, pre-oxygenation for them may be CPAP or maybe a BVM. But either way, I would put your nasal cannula on up front so that you can get ready to use it for apneic oxygenation. We've talked about why we can't stop at 100. It's because you're going for nitrogen washout that you may not see on your SAT. Your pulse ox doesn't tell you anything about how much nitrogen they got left in their airway and how little reserve they have. So troubleshooting a hypoxic patient, Rich Levitan proposes oxygen on, pull their mandible forward, so distract their jaw. We call this a jaw thrust, just a jaw thrust, nothing fancy, and then sit them up. And that can take this from this to a more patent airway. All right, BVM. Who was taught the EC method in school, medic school or whatever? I sure was. Who feels like the EC method is easy to do and works well? We'll talk later. No, I'm just kidding. It is, I think, sometimes it is easy. I think in general, the problem with the EC method is it really requires 2 people, and I just don't think it does a very good job. What I actually think is better is something called the thumbs down technique. I hope he still has this video up on his website. Oh, yes, he does. This is not British, so.
Ventilation is the most important skill in airway management. It is more important than
He's a little
laryngoscopy.
robotic. This is an emergency doc out of
If you
New
are
York.
outstanding at laryngoscopy, but average at ventilation, you're in a bad position because you will encounter patients whose airways present challenges that you did not anticipate and are unprepared for. And these are invariably the patients who are most difficult to ventilate, so this leads to bad patient outcomes and a sad doctor. If you are average at laryngoscopy but outstanding at ventilation, things are good. Because when ventilation is successful, when we stay on the left side of this line, it is a happy day. regardless of what's happening or not happening with laryngoscopy. When you can ventilate, you can take as long as you need, perform as many airway attempts as you want. The pressure is off. It's a happy day. When you cross over to the other side of this line, when you cannot ventilate, you have entered the airway death spiral, where you are called upon to perform procedures that you are not comfortable with as quickly as possible, at the same time that your own heart rate is 150, your palms are sweaty, and your underwear is soiled. How many pairs of underwear you buy in your career depends mostly on how good you are at ventilation. Ventilation is the superstar skill in airway management, yet we spend a lot of time thinking about, talking about, and practicing laryngoscopy, and nearly ignore ventilation. Furthermore, when we're involved in an airway disaster or an almost airway disaster, we tend to consider this a failure of laryngoscopy rather than a failure of ventilation. We kick ourselves for not being better at laryngoscopy, for not having mastered some new airway toy. But this is like attributing the death of a trapeze artist to having poor mid-air acrobatic technique, rather than recognizing that the problem was his preference to perform without a net. Bag mask ventilation is the most important emergency ventilation technique, if for no other reason than it is universally available. It is the cornerstone of emergency airway management, the skill that keeps you out of the airway death spiral. And almost all of us learned how to do it wrong. This is how most of us learn to do bag mask ventilation.
Familiar?
It is called the CE technique, for the C your thumb and index fingers make around the inlet, and the E your last three fingers make around the patient's mandible. Most of you probably use this technique routinely, and it is the wrong technique. Every month or two, I'm involved in an airway management scenario and observe a provider bagging this way. As the saturation falls and everyone is freaking out and losing their mind, which is the easiest way to recognize the start of the airway death spiral, I courageously step in, use the correct technique, and the saturation comes up, and suddenly it's a happy day again. I'll then step out of the way and ask the person who was bagging before me to do it the way that I did it. And it works. The correct technique is easy. So why did we all learn the wrong technique? We learn the wrong technique because we learn to bag mask ventilate from anesthesiologists. Anesthesiologists use the CE technique because they bag patients as part of their routine, and it is important to an anesthesiologist to be able to bag alone, without assistance. So they need to be able to hold the mask to the face with one hand, so they can use the other hand to bag. Being able to hold the mask to the face with one hand is not important to an emergency physician. An emergency physician wants to use the technique that is most likely to be effective on the first try, because when an emergency physician is doing bag mask ventilation, it is not part of a routine, calm, everyday start to another cholecystectomy.
Right, so
when
we just want to do what
physician
works.
is bagging, it's usually to
Not
avoid
what
entering
requires
the
the
airway death
fewest
spiral.
amount of people.
The CE technique is convenient to perform with one person, but it is not the most likely to be effective on the first try, especially for people who don't do it every day. The nurse can compress the bag. If your resuscitation bay is like mine, the patient in the next gurney over can compress the bag.
So look at this technique with the
Even
thumbs
an
down. Does this look
administrator
familiar? I think
can
we've gone
compress
over
the
this
bag.
at least once before.
Anyone can compress the bag.
Thumbs down
You,
and pulling the
airway
face into the
expert,
mask.
need to have both hands on the mask.
So you're doing a jaw thrust
If
simultaneously.
it's just you, your patient, and a bag valve mask apparatus on a desert island, you still don't use the CE technique. You use the two thumbs down technique and compress the bag by positioning it in between your chicken wing and your body.
So this is what he recommends as a better
When
technique,
you
and I
use the
agree
two
with
thumbs
that.
down technique, your palms surround the mask and you know exactly when and where there's an air leak. And you have maximum maneuverability to shift the mask to fix that air leak. Lastly, and very importantly, with the two thumbs down technique, you are using the strong muscles of your hands and arms.
All right, has everybody seen this? You understand it?
We
Ready to move
evolved,
on?
or were intelligently
Nods.
designed, to grasp objects using
I know,
four
right? He's a
fingers.
big Rocky-Ronium. He goes on all kinds of rants, most of which are excellent, but he's a big Rocky-Ronium guy. All right, how do you make your tube? Who knows what I mean by straight to cuff? I'm going to get an example. Somebody tell me what I mean by straight to cuff.
Only bend it at the cuff.
Yeah,
Bend it at
bend it at the cuff. Why is that valuable?
One like a hockey.
Exactly. So why do it that way, though?
Because, I don't know, it's just easier.
I agree, it is easier.
Why's it gotta be technical?
So straight to cuff means straight, and then you get to your cuff, and then you make about a 35-degree bend. And the reason for this is, as opposed to the bow, where you do kind of an arcuate shape, this allows you to manipulate the end of your endotracheal tube with the least amount of obstruction of your field of view. So if I'm trying to intubate somebody and this isn't a bow, and I'm trying to go like this, what's the problem with this in terms of my view of the vocal cords? Yeah. I've seen anesthesiologists do it that way, and I'm like, how's that going for you? Because I don't know if that's helpful when, like, the crap's hitting the fan. So with this, you come in from the side of the mouth, and you can actually toggle this up and down to get it where you want to go just by using the distal tip or the distal portion of the endotracheal tube. So if I'm coming in, I'm like, oh, I'm heading for esophagus, all I got to do is toggle it from the side of the mouth, toggle it up. Does that make sense? And now there's minimal obstruction in my view, because all that I'm looking at is basically this part, instead of this giant ET tube that's blocking the exact line of sight that I need to get my tube where I want it to go. So 100% of my tubes I make straight to cuff for this reason. One thing you'll see that if you're ever just randomly watching me intubate, you'll see I always make my stylet this little tab at the top. And we'll talk about that a little bit. You want to keep it about 35 degrees. Any more than that, and you end up getting a lot of hang up when you're trying to progress through the vocal cords. Any less than that, and you'll end up angling toward the esophagus. And just remember, this is an optimal configuration to the arcuate shape. Why no more than 35 degrees? This is just a study that shows you're more likely to encounter mechanical hang up in the vocal cords, like I just said. All right, positioning. What do I mean by positioning? Super underrated. Some of you mentioned it earlier. Positioning, ear to sternal notch is how we're supposed to position patients. Literally, ear to sternal notch. And why are we doing that? What's the point of that?
Right stone.
What?
So you don't right stone. So you don't stick it too deep. Correct? No.
I'm trying to think that one. No, I don't think. I can't think of how you would.
You're saying from ear to sternal, isn't it for the distance?
Oh, to measure. Oh, certainly. Yeah, you might be able to eyeball before you go in, but I'm saying how we actually position the patient. With their ear aligned with their sternal notch. So sternal notch is right here. It's that thing, the intersection of your neck, and then their ear. But I see what you're saying, is you could easily measure the tube and try to gauge it.
I thought that's what you were getting at.
It's all right. I want you all to kind of picture this in your head. And the next time you're getting ready to intubate a patient, just take 5 seconds and ask yourself, are they ear to sternal notch? And if they're not, how do I get them that way? So for some patients, they may need more back support. For some patients, they may need more head support. For some patients, they may need a huge ramp of stuff to get them in better alignment. And what this actually does is this aligns all the axes of the airway. Because ultimately, what you're trying to do is look down through here. Your eyes are here. You're trying to look down through their oropharynx, which is angled this way. And you're trying to get the tube in to the trachea, the vocal cords that are angled this way. And the ear to sternal notch position best align these axes. This is particularly good for the obese, and these are the people that you may need to actually ramp before you intubate them. But odds are you're not going to have much time. So just take a second to look around and say, do I need to throw a towel under their head or under their shoulder blades to get their ears parallel with their sternal notch? So this parallel bar should be, this bar should be parallel to the ceiling. Ear to sternal notch positioning. That's the optimized way to intubate somebody. Does that all make sense? All right, we're going to keep on trucking. Things that only worsen your intubation view, believe it or not. Flexing the patient's head you know about. Hyperextending the patient's head can make it worse as well. So just be mindful of this. Ear to sternal notch is not extending. A lot of times you'll see people that just, we need to just extend their head more. That's not always the solution. And this guy, Rich Levitan, studied this. Last off, where do you put yourself? And this is going to be less applicable to you guys because very rarely are you intubating with somebody on a gurney. But if I had my choice, I would try to position a patient such that their head is actually at my sternum. So to me, if you put the patient on a stretcher and you decide you're going to intubate them randomly with the stretcher elevated, that's pretty similar to the hospital environment, where if I can get a patient's head to my sternum, I'm probably going to be able to troubleshoot an airway that a lot of people would struggle with more effectively because my line of sight. So if I've got the patient down here and I'm trying to look down at their airway and get into visualize their vocal cords, am I going to have an easier time doing it up here like this, or if the patient's like this relative to me? Higher up. Yeah. So they've studied this. And they've actually found that having the patient higher up on the operating table in the operating room has been easier for anesthesiologists to do it. So certainly if you're ever in a position where you can elevate the patient's head with respect to where you're intubating to your view, then please do so. That's why there are some medics that like to intubate. If they got a cardiac arrest patient, they'll lie down prone on the floor with them. If I ever intubate in the back of a squad, I will sit the patient up just a little bit. I'll put the head of the bed up, and I will either, if I could put the head of the bed up all the way, I'll actually bend down and intubate from above. Or I'll put the head of the bed up a little bit, let's say if they're on a backboard, and I will actually squat or get on my knees at the head of the stretcher so that my eye level is low relative to the patient and their head is relative to me. So just be mindful that getting that line of sight so that you're down and the patient is up will allow you to see into what is otherwise a very anterior or elevated position. Does that make sense? Getting the patient elevated with respect to you. Deploy the blade strategically. So am I really talking about how you should stand with position with respect to this? And the answer is yes. If you do find yourself in a position where you're intubating somebody, either they're on a gurney relative to you, if you go to the OR, for example, or if you decide that you want to sit the head of the bed up, remember to keep your head back from the patient. So if I have a choice between intubating somebody up close where I'm like this, or back where I'm like this, which is better? Yeah. And they truly have studied this, and they found that experienced anesthesiologists were much more likely to hold the blade closer to the hinge and to stand back, because that gives you better visualization and, again, aligns that axis. Whereas if you're up close, you're looking straight down, you can't actually make that turn with your line of sight. So keeping the patient up and leaning back are how I'll troubleshoot some of my most challenging airways. So amateurs were crouched, they were closer to the mouth, and they had their elbow bent. Pros stood further back and go like this. It looks ridiculous, but it gets the job done. If we have somebody where the stretcher has to be low because we're doing CPR, I'll get down on knees like I'm proposing to them, basically, and get down on maybe one knee and change my point of my line of sight that way. So this is just what you saw in the video, where he was real close and he's just looking down. Experts, they've studied. Look at this guy. This is exactly how I would intubate somebody that's getting compressions. This is like a secret cheat to anterior airways that I don't understand why more people don't do it. Remember, consider holding it closer to the handle. That gives you better fine motor control. And there are two stages of holding the, I should just grab the blade. There are two stages of holding the blade. In my mind, there's the gentle method as you're inserting it, and then there's the forceful lifting. And what you don't want to do is confuse the two, because the transition to forceful lifting should be very clear, and there's really only one time you want to do it. I'm going to use this. Let's see. There's a Mac 4. All right. So as you're inserting, you could hold it however you want. You could hold it like this. I don't care. 2 fingers, half a finger, whatever. Inserting very gently, navigating the tongue, and now you get to this point where you're ready to lift. And when is that moment where you're ready to lift? Where is the end of this when you're ready to lift? The vallecula. Mack versus Miller. I take this poll like every time I give this talk. Mack, raise your hand. Miller? Wow. You have like a West Side Story standoff now between the Macks and the Millers. So I'm a Mack guy personally. I look like an idiot trying to use a Miller. I can use it with kids, but with adults, I usually prefer Mack. But this is totally a preference. There's no literature. Do whatever works for you, whatever you're the most comfortable with. I Mack for pretty much everybody unless they're like the tiniest of grandmas, in which case I might consider a Mack 3. Tongue control is really what is the most essential. So just like I was talking about, coming in from the right, sweeping to the left. This is nothing new to you guys, so I'm not going to belabor it. But one thing that we'll emphasize is starting with the epiglottis. This is like the super essential requirement of intubating as far as I'm concerned. And I don't know if this is if this is just a given, where y'all were like, oh, this is how I was taught, this is how I've been doing it for years, doc, or this is something that's new to you, but the epiglottis should be the only thing you're looking for when you get in the mouth initially. And the reason for this is truly the landmark of the airway. And I think when people try to just do it all in one fell swoop and try to bypass epiglottis and just get it in the airway, you're more likely to end up with an esophageal intubation, and it's going to take you longer to get a hold of the trachea. Because once I know I'm in epiglottis and I'm seated in vallecula, I have 4 troubleshooting steps that I'm going to do no matter what. That once I'm in that spot, I know what I need to do to get to trachea. And if I've done those 4 things and I'm still not seeing vocal cords, time to move on and try something different. Does this anatomy all make sense? We're inserting our blade right here, lifting this epiglottis. What if you can't find it? So you're going in, you're like, the doc said, look for epiglottis, look for epiglottis. Don't think about anything else. I'm looking for epiglottis. Where the hell is epiglottis? What are you going to do? Pull back and what?
Reoxygenate or just pull back a little bit and see if you see it pop in.
Pull back, exactly. So sometimes you might have bypassed it. So if I'm like, I advance and advance and I don't see it, I don't try to be a cowboy and just look right for cords. I'll say, wait a second, I don't have epiglottis. Hold on. Back up a little bit. And then just re-advance. And if you're still having trouble finding it, make sure you're midline. Because while normally we want to sweep the tongue from the right to the left, finding epiglottis depends on your blade being midline. Remember, there can be camouflage, so you got to make sure you suction, blood, saliva, vomit, all that stuff. And it can also get stuck up against the posterior wall. So sometimes even going in with your Yankel or suction, not so much to suction, but just to kind of like poke a little bit, will get the epiglottis to drop down. Make sure you suction all those secretions, then remember to advance slowly midline. All right. Now this is what we're really here to see, right? Given an airway talk, you got to talk about how you're going to actually find the vocal cords. And my goal through all of 3 anesthesiology rotations between med school and residency, and all my air care, all my ER intubations, all that, my goal was simply to walk away from all of that with key troubleshooting steps for each of the 3 phases of intubation. So you heard mine for epiglottis. It's basically just back up, try midline. What if you can't find cords? So you're in epiglottis, you found epiglottis, you're in vallecula, I should say, and you can't get a good view of cords. What are some of the things y'all do?
Aim for the bubbles.
Aim for the bubbles. When in doubt, if it's a bloody airway, aim for the bubbles. Sure.
Suction.
Suction. Try to get a better view.
Maybe try to reposition the head a little more.
Try to reposition the head. So that was one of my troubleshooting tricks. So first of all, these are the various Cormac-Lehane glottic views. These are different than Malampati's. So this is grade 1. This is perfect. This is like the first prize. Second place prize, because you can see a little bit of posterior notch I was talking about earlier, but you don't have a great view of cords. I don't like this view. This is epiglottis only. And this is 4. This is where you haven't even found epiglottis yet. So this is the one where you should back up midline. What do you think needs to happen here to get a better view of the cords? Like, looking at this picture, I reflexively want to do it. What do you have to do right now to get a better view? What's that? Advance. That's exactly right. All you have to do right now is advance. And I don't mean lift. Don't lift. Do not lift. This can still be the very gentle 2-finger mode, where you're still just like, oh, I see epiglottis. And until you are confirmed locked in that vallecula, not until you've done that do you transition to the lifting. Because right now, if you lift a lot, you're not going to get a much better view. And that's where I see a lot of people, a lot of novice intubators, where they're like, oh, I'm lifting, I'm giving it all I've got. And they're doing everything they can to lift that epiglottis out of the way, and they're not getting it out of the way. It's because they're not triggering the higher epiglottic ligament, because they're not fully seated in the vallecula. So you guys have already named 2 of the most important troubleshooting steps for getting a good view of chords. Make sure you're locked in the vallecula, and then, as you said, reposition the head. And that's lifting the occiput. So if they don't have C-spine issues, this can just be your plain old cardiac arrest. While you're looking, once you're done suctioning, you got a free right hand, say to yourself, first of all, am I locked in the vallecula? That should be first. Am I locked in the vallecula? You still don't see chords, you're lifting. Now you can lift, right? Because you're locked in the vallecula. Lift. If you still can't see it, lift up the back of the head just a little bit. I'd say about 50% of the time that fixes everything. And I don't even need somebody, like you could ask a partner to hold the head right where you got it, or you could just try to make it take it. Because there's something about, once I've gotten in that position, I can kind of hold that view myself. I don't know how. But that's the next thing, is lock in the vallecula, gently lift the occiput. Now what? You still can't see chords.
Bigger blade.
Bigger blade. So I guess there's a possibility you're not fully seated in the vallecula. I think a bigger blade would help there. Or you switching from a Mac to a Miller if you really feel like you can't get epiglottis control no matter what you've done.
You're offline.
What's that?
You're not midline.
You might be off. Yeah, that's true. So especially, I've seen in kids where they have a lot of anatomic deviation where you're like, you're lateral. And that doesn't even make sense. You're like, why would it be lateral? But you can be. This is usually where I ask for somebody to retract a lip if that's in the way. So sometimes the patient's upper lip may actually be obscuring your view, or their lower lip. And you can ask for somebody to retract their lip. So always ask yourself, is this a lip issue? So I lock in the vallecula, I'll lift the occiput, I still don't have a great view. Is this a lip issue? And if so, have somebody retract it. If not, move on to the last thing. And this is really the last option I got without switching to another device that you guys don't have, maybe one day will, which is the Eschmann stylet, or the bougie. I'm talking with the chief about getting it. It's pretty cheap. I don't know why we don't. Anything else you want to do? Change innovators. I agree with you. I would try one more thing real quick before I do. Who's heard of Celix? Cricoid pressure. Everybody's heard of it? Good or bad?
Usually bad.
It's bullshit. Usually doesn't work. It's not. It makes this claim that Celix is like one spot on the neck that you just press and magically like cancer is cured, right? That's not how Celix works. Celix is very, very infrequently the solution, and it can actually compress the trachea and make your view worse. What can make things better is when the operator, the person that's seeing the view, reaches over and grabs the patient's neck. And there's nothing secret here. There's nothing special you're going to do. It is literally grab their neck, their larynx, not their whole neck, but grab their larynx and move it and push it in and move it until you get a better view. And that's called external laryngeal manipulation, or bimanual laryngoscopy, meaning both hands. So you're visualizing with your hand on a laryngoscope, and you're manipulating the larynx. And this, a lot of times, will get the trachea to drop into view. So my 4 troubleshooting steps, when I see epiglottis, I'm like, sweet. I make sure I'm locked in the vallecula. I lift the occiput of the head, see if that helps. Nope, that's not helping. Can you try give me a little lip right now? Okay, a little lip. No, that's not helping either. Hold on. Here, let me try manipulating their larynx. Rightward does it. Some people hear like backwards, upwards, rightward pressure, burp, right? Sometimes that doesn't work. Sometimes backwards and upward isn't what I need. Sometimes it's the opposite direction, downward, whatever. I don't care what direction, because everybody's different. So you can use the direct feedback you're getting from your own hands to change this until you get a better view. I very rarely, as somebody that only chooses to do DL on all my intubations, unless somebody tells me that I can't, which is pretty rare, very rarely can I not get a tube with DL using all of these troubleshooting steps. Sometimes I have to go through all of them, and sometimes it takes a good 15 seconds in my head to say, okay, try this, try this, try this, try this, try this. But these troubleshooting steps can get you most of your views that would otherwise be challenging. And then let's say you get the larynx in the right spot and you're loving it. You're like, that looks great. ask somebody to hold with the exact amount of pressure. And they can even kind of demo it. While your hands are still there, they can kind of press and say, okay, I see where you're pressing with this amount, and have them hold that view, hold that position. And you have to be clear with that, right? Because if you just give it to anybody, they might think that you mean sell it. Because I've had that happen before, too, where I'm like, hold this right where I'm holding, and they think, oh, yeah, I got you, you want cricoid pressure, and they hold it, you know, somewhere totally different than where I'm holding. So you have to be clear, hold this exact spot. But these 4 troubleshooting steps, I think, can be the solution to 90% of our difficult airways. We just talked about this. I don't think I need to show you a giant soapbox rant about cricoid, but this is out of the guy Levitan. He's kind of known as the airway guru in emergency medicine. And just to kind of remind you that cricoid, like one singular spot on the neck, is not helpful. We don't do it well. Sometimes people will do it because they say it prevents your risk of regurgitation aspiration. It doesn't effectively occlude the esophagus. It more often than not occludes the trachea. And it can ultimately worsen your view. So he hates it, and I agree with that. All right, last thing you got to accomplish in terms of an intubation, passing the tube. Who's had issues where you got a great view of vocal cords, but you just can't pass the tube? Anybody? What have you done?
What have I done to fix it?
Mm-hmm.
Pull back out, maybe adjust it.
Okay, so adjust your tube.
My grip.
So one option is maybe your tube is, obviously if you're going in with like a tube at 90 degrees, it's pretty easy for that to scrape the cricoid or the tracheal rings and end up with issues as a result of that. So yeah, so I agree that is one thing you can do, is just to adjust your tube. So remember, if you're going in straight to cuff and you're coming in from the side, you can toggle your tube to get it anterior and to get it where you want to go. And a reminder that this is not the right way to do it, right? Because that's just going to be obstructing his view. That's the good way to do it. So the classic complaint of, I can't get the tube to pass, I think is most easily troubleshooted by first rotating. So if you're coming in like this and you're hung up on cords, just rotate. And I mean, they say 90 degrees to the right or to the left. I can never keep track. Same thing with the bougie. For those of you that do use an Eschmann stylet or a bougie, if you feel like that's getting hung up, sometimes they say the left, sometimes the right. Just rotate it 90 degrees, just like manipulating the larynx. Rotate it 90 degrees in some direction and see if that works. So you're hung up on cords, or you're hung up on tracheal rings. Rotate it this way, try to advance. Nope. Rotate it this way, try to advance. Nope, doesn't work. Now what?
Maybe it's too big. Maybe the cuff's filled.
Maybe you need to downsize.
Need some lube.
Maybe, absolutely. So I think taking out the tube and checking your tube, remolding it, applying some lube, or downsizing it are all good thoughts. The one thing I do before I do that, though, is I back my stylet out a little bit. And this is why I make my tubes the way I do, with a little toggle right here. Because if I'm by myself, or if I've got a flight nurse that's busy getting ready to get the patient out of the ambulance, or watching the monitor for me, or getting the end tidal set up for me, and I'm in there, and I realize I need to actually back the stylet out a little bit because it's creating this sort of hard, not very malleable end of the tube. All I got to do with the tube kind of situated in the patient's mouth is just slide my hand up and go like that. And I can back the stylet out just a little bit, just enough to make this distal tip more malleable. And I found that to be pretty helpful, and that's actually helped me out and gotten a tube to pass that I think otherwise wouldn't have. So just keep that in mind. Rotate the tube 90 degrees, and then retract the stylet. If you want to have this kind of tab at the top, you can. And I think it's helpful to let you do it on your own. Or you can just ask somebody, hey, pull my stylet just a little bit. Don't pull it out. You have to be clear, saying, toggle my stylet just an inch. Don't pull it out. And then your thoughts about lubing it up or changing the tube position are all great ideas. So wrapping things up here. So what we just talked about, that's all what I consider optimized endotracheal intubation. So this is my idea, my conceptualization, stolen with a lot of stuff from Ruben Strayer and Rich Levitan, guys that are smarter than I am with respect to airway. This is all my attempt to kind of give you troubleshooting tips to give you the most optimized intubation attempt you could possibly have. With that in mind, are we going to be able to intubate every patient? Even with the best technique, no. So it's not about, like what Strayer said, it's not about intubating, it's about ventilating them and getting them oxygen. So these are all great things, But this is not about being that hero cowboy that just got the patient intubated, right? This is about doing some other things that can matter and get the patient oxygenated. My shoe just came off. That's awkward. So let's talk about alternatives to intubation. What is our alternative here that we think of? King. Bag them. So you could just drop 2 NPAs and bag them. It's always an option, especially if you're just 3 minutes away from the hospital. Because if they're bagging fine and you think that you can make the transition from ambulance through ED doors to trauma bay, just bagging the patient, maybe that's best for them. Because as much as I like kings, when you put in a king, it does introduce a little bit of airway edema that might make them harder for the next person to intubate. But certainly don't hesitate, because at the end of the day, if somebody isn't bagging well, you've got to put in a king. That's just got to be reflexive. If you can't bag them up and you're doing the things we talked about, the thumbs down technique, you've lubed their beard. If they don't have dentures or they're missing their teeth, you can put the base of it in their mouth and bag through their nose. You've tried all of that, and they're not bagging up. That's a problem, right? So that's when you need to think the king. And if that doesn't work, then we got our needle option. So first of all, what other things can we do to help intubation? We've talked about apneic oxygenation. You can suction. You could try a different blade. I almost never will go to a Miller as my backup, because if I can't get something with a Mach 4, then I might try a bougie if we have one, or I'll just abandon that and try something like the King Vision. Don't forget your crew, right? So you can use people as resources, not just as another intubator, but if you got a bloody airway, have somebody else. Don't try to do it all. Have somebody else suction. If you have a tough airway, don't forget you can have somebody else pull lip, just like we talked about. If you have a really tough airway, have somebody start prepping for crike. This is important. Like, we've had airways in the SRU where things are going pretty shitty, and we say, can we open up the crike kit, please? And the nice thing about that is, while we may never use it, at least we're ready. The last crike I did in the SRU, I was like, I'm pretty sure we're going to have to crike this patient. They were like, well, let's give it another try. And I'm like, can I set up? And they said, yeah. So I got my scalpel. I marked my site with a Sharpie. I was standing there, and guess what? When they were like, oh, we can't get it, crike, 7 seconds I was in that neck and in the airway and had a tube in. Because we're ready, because we're standing there. Everybody's on the same page. We've all said it. We all know what's going on, and it makes it easy. So don't be afraid to say, guys, I think we need to have somebody set up to do a needle crike while we try one more attempt at this airway. That is respect. That is awesome. All right, so what's the goal?
Have a patient walk out of the hospital.
There you go. Have a patient walk out of the hospital. That's the true goal. Oxygenation, ventilation, have a patient walk out of the hospital. The same thing, right? Essentially. Goal is keep the SATs up, keep their brain oxygenated so we don't get an anoxic brain injury. All roads do not lead to Rome. Intubation is not the only option here. All right. Who's heard this story before? You remember this? You remember this? Nobody remember this? You remember this, Scott? Yeah. Mom in England, pilot, husband, went into the OR for routine surgery. Her airway obstructed when they pushed sedative. She got hypoxic to the 50s. They perseverated on intubating her. Everybody and his brother came in to try to intubate her. Anesthesiologist after anesthesiologist after anesthesiologist. This is sinus surgery, routine sinus surgery. They attempted a supraglottic airway, and that didn't work. Nobody said this is a failed airway. Nobody even considered the possibility that this airway would fail, even though there is certainly such a thing as a failed airway. Nobody was willing to admit that. There was a nurse who wheeled over a crike kit and said, here's your crike kit, whatever they called it in England at the time. But she never kind of pushed the issue. Nobody listened to her because, I guess she's just a nurse. She had the best suggestion of the entire team. Everybody kept trying to intubate. Nobody listened. She ended up dying of anoxic brain death, and they withdrew support 2 weeks later. So the main take-home points is, remember oxygenation. They did nothing in the way of apneic oxygenation. They did not try to keep her SATs up. They tried to intubate and intubate and intubate and intubate. Use all your tools, and don't forget to listen to people who have suggestions, even if it's the newest member on the crew. So this is like my little rocket to airway success. I'm grabbing this for you. Yeah, I made it. Yeah. Yeah. It was a lot of fun clip art. I played around with it. Anyway, so I don't know, I just found a picture of a rocket and it seemed like this all worked. So this replaces a lot of these fancy airway algorithms. I don't know if you ever looked at like the ones we're supposed to use in the ER, this like failed airway algorithm. It looks like the electrical map for New York, or the subway map for New York City. Like it's just like do this, then that. Maybe if this doesn't work, then try that. Then sit on your hands twice and spin around. It's like none of it's actually relevant in a truly crash situation. So to keep it simple, you try an optimized endotracheal intubation attempt number 1. So let's say this is a patient that's like GCS of 3, a heroin overdose. They're not responding to Narcan. They've still got pulses. You put the apneic oxygenation on, you bag them up, you get them oxygenated the best you can, you get them denitrogenated the best you can with your 8 full ventilatory cycles, and you're like, all right, now we're gonna breathe for them. Now we're gonna try to intubate them. Optimized endotracheal intubation attempt number 1. You do all the right things. You find the epiglottis, you see the epiglottis, you get locked in the vallecula, you can't see cords. So you lock in the vallecula, you lift up, you lift the occiput, you ask for lip, you get a little bit of lip, you still can't see cords. You try to move their neck, you do laryngeal manipulation, you still can't see cords. Okay? Your partner says SATs are 92. What do you want to do? Come out and bag them up. Great. You bag them up. Great. They bag up. What do you want to do differently this time? You want to try the king vision? Maybe they're super anterior? Oh, okay. What do you want to do now? New intubator? All right, somebody else try manual. Somebody tries with a Miller blade. Take a look. They do all the right things. They actually lift up the epiglottis. They try to do all the same things to see cords. They lift the back of the head. They pull lip. They manipulate the larynx. Can't see cords. SATs are 91 now. What do you want to do? Come out and bag. This time, you pissed them off. All of a sudden, you can't bag them. Why do you think you can't bag them? What? Edema? What about with the airway?
You've aggravated and it's closed up.
Laryngospasm. You put them in a laryngospasm. Now you can't bag them. You go to bag, you're getting a lot of resistance. A lot of resistance. Their SATs are 88, 87. You want to cut their neck right away? Probably, hey, if you get a definitive airway because you need to, and somebody's hypoxic, you can't intubate them, you cut the neck, I'm probably not going to fault you for it. What I would, well, but you knew that was laryngospasm because we confirmed it for you. But if you just had the generic patient and now they don't bag up, what are you going to do? You're right here. You're right here. Where are you going to go? Which direction? You want to go to a king. SGA. What does that stand for? Supraglottic airway. You want to try supraglottic airway. So you put in a king. What does the king do? Jack shit. Because they got laryngospasm. Now what?
Now you got correct.
Walk me through it.
Now you got to put it in their neck.
How are you going to do it?
Put a hole.
Find your landmarks. The first thing, honestly, the first thing that, and I think I talked about this before, the most important and courageous leadership step that you can take on this entire run is to say, however you want to say it, I don't think we're getting anywhere. We're not oxygenating this patient. We can't intubate them, we can't oxygenate. However you want to say it, this is a failed airway. Guys, we all want to change our pants. Like whatever. I want somebody on the crew to say, this is not working. We need to cut the neck. Or needle crike. As long as it's been said, because then at least it's been considered, and now there's not going to be, because the worst thing that happens in these scenarios is people muck around. They beat around the bush, where they're kind of like, well, maybe let me try, let me see, and meanwhile SATs are 60, SATs are 50, and getting all distracted in that chaos, and the pulse ox falls off. I mean, this is how these things go. And next thing you know, the patient Brady's down and they arrest of hypoxia. So early on, I'd say by the time you get to here and you're like, they can't bag, while you're putting in the king, I have somebody else, I would say, hey, let's put in a king. We can't intubate. Let's put in a king. Get out the crike kid. Is it pretty accessible in your truck? That's good. So we got no excuse. So then you get to here, you cut the neck, you get in, you bag, SATs come up, everything's great. Good job.
How hard is that? How long does that take to heal on a person when you do that?
Matter of weeks. They'll convert it in the OR, assuming they can't get them intubated from above. They'll convert it to a trach in the OR like that day or the day after, and it's not a big deal at all. It's really not. I mean, like, we'll trach people in the ICU after 3 days of them being there. If we don't think they're going to come off the vent anytime soon, we'll trach them, send them to rehab, and a few months later they get it closed up, and that's that. They got a scar saying that they went through a lot, but they lived to talk about it. Yes, sir?
How well did the needle cracks really work?
I'm not honestly that familiar with them. I mean, the kits that you guys have, they're pretty easy. They're about as easy as it gets, I think. You mean in terms of ventilating?
Yeah.
You could ventilate okay. I mean, it's essentially the same as putting in a 6.0 ET tube, which is what we would do if we surgically correct them. So if I surgically correct somebody, odds are they're getting maybe a 6.5 if I'm generous, 6.5 ET tube over a Bugier and Eschmann, and that's going to be about the same as these needle crike kits. You know, you're not going to be, they're not going to love it like they would an 8.0 ET tube, but it gets the job done. Because remember, our goal at that point, by the time you're getting to that point on the airway rocket that I drew out there, you don't care about intubating them, you don't care about ventilating them, you care about oxygenating them. So 10 steps to successful intubation. Use your apneic oxygenation. Remember to denitrogenate the patient. Remember your straight to cuff 35 degrees for the best view. Come in from the side. Ear to sternal notch position with that ear to the sternal notch, that bar parallel to the ceiling above you. Don't forget to use the blade strategically, meaning you're sweeping to the right. Find the epiglottis. Start with the epiglottis every single airway, every single time. I promise you it will not lead you astray. Because as soon as you find epiglottis, if you're using a Mac, you know what you got to do. If you're using a Miller, you know what you got to do. It's going to be the guide to all of this. If you're using a Mac, then make sure you're locked in the vallecula. No matter what blade you're using, lift the head, have somebody pull lip if it's in your way, and move the larynx on your own so you can find the best spot. If you're having trouble passing the tube, don't forget you can rotate the tube 90 degrees and then retract the stylet about 1 inch. Don't forget all your adjuncts, including your crew, and never forget the goal, which is oxygenation by whatever method necessary. And then the simple airway algorithm is you attempt an optimized intertracheal intubation. If that fails and you can't bag them up, put in a supraglottic. And I'd say when you call for the supraglottic, when you say we can't intubate them, let's get out a king, get out the needle crike with it. Because you don't want to be in a position where you're already getting the supraglottic and you find out that doesn't work and you find out too late when their sats have already dropped. So get ready to have a needle crike in that patient's neck when you pull the supraglottic. If you're interested in this kind of stuff and you want to hear a lot of the primary literature, the primary research that this talk came from, Rich Levitan's site is called airwaycam.com. They've got some pretty cool intubation videos and stuff that you might like on there. So we've got another maybe 5, 10, 15 minutes where I'm happy to stick around. Let's muck around with some airways in the back and try to put all this into practice if you all are open to it. Sound good?
Sounds great.
All right.
Keep talking about nitrogen.
Denitrogenation?
Yeah,
Because basically nitrogen gases are what's in your lungs.
I've just never heard it before, to be honest with you. No, I've always heard people talk about CO.
Pre-oxygenation?
Yeah, and
yeah. The reservoir in your lungs that we talk about in terms of reserve, that's all nitrogen. So we need to get rid of that before we can give a patient adequate reserve.
What, about 70% nitrogen, something like that?
Yes.
No, I know all that. I've just never heard it in a training.
Neither.
Well, you heard it now.
So, off topic.
Please.
We carry labetalol in Rock 9 for hypertensive emergencies.
Yeah.
I gave some to a lady the other night. And when I walked into the ER, all of the nurses and the physician looked like I had a penis growing out of my